lesson, we are going to be talking about the diagnosis enuresis. Enuresis is the inability of a child to control their bladder after the developmental age that we would expect to see that. Now, for the most part, we expect kids to have this ability by 5 years of age. And that varies a little bit with kids, but for the most part, that's our average age that we would expect that. Now, before the age of 5, even if parents are super frustrated by these accidents, it is not considered abnormal, and a kid would not have the diagnosis of enuresis. The diagnostic criteria for this is to have accidents 2 times a week for 3 months in a row or more. Enuresis can be classed as either diurnal, which just means that it's happening during the day, or nocturnal, which is sort of nighttime bedwetting, which we're probably really familiar with, or it can be mixed where the patient's having both. It's also really important to make the distinction between primary enuresis and secondary. Primary is when the child has never been able to achieve dryness, so they've always had bedwetting, they've always had accidents during the day, whereas secondary means that they have at some point been completely toilet trained and they've had dryness and control of their voiding, but now they don't. Developmentally, we would call this a regression. So secondary enuresis is a regression. And usually when we see a regression in any kind of developmental situation, we really have to think about looking for an active medical problem that's causing this. And that's true for enuresis as well. So if we have a child that's developed secondary enuresis, we have to think about what could be causing that. So let's take a look at these different causes. I've categorized these causes as being common things that we see, and then also the things that are super important to rule out that we don't want to miss. So on the common side, you have slow development. So some kids just having a little bit of difficult time, taking a little bit longer. They may still outgrow it. And then anxiety and stress is a common thing that can cause it. So for an example, it's not uncommon to see kids who are diagnosed with cancer or some equally difficult diagnosis to develop secondary enuresis as a result of the stress and the drastic changes to their routine. Then you also have genetics and family history, which can contribute overactive bladder. And then the last one is just an idiopathic enuresis, which just means that no obvious cause can be found. So the important things that we need to rule out as possible medical causes are things like spina bifida, or really anything that would cause a neurogenic bladder. And neurogenic bladder just means that there's some kind of brain, spinal cord, or nerve injury that's caused a lack of neurogenic control over the bladder. Other things are new onset diabetes. Remember, that causes an excessive increased amount of urine output, which can cause loss of control of the bladder. And diabetes insipidus does the same thing. And then 2 of the most common medical causes that we see for secondary enuresis are UTI and constipation. For your assessment, you really want to have a really extensive chat with the family because you need to find out what's been going on. You need to know how often it's been happening and what the circumstances are surrounding these accidents. And another really important part of history, like I said, is finding out if the child was previously toilet trained so that you can establish if it's primary or secondary. Asking questions about the child's daily routine is actually going to give us some really important clues for how we're going to manage this. So get details about their hydration status, what are they eating, what are they drinking, and then what is their routine like at home and at school? Are they comfortable using the toilet at school? All those little things are going to help us manage this. Then you really want to ask questions and look for signs of possible causes and contributing factors. So are they constipated? Are there signs of infection or new onset diabetes? Do they have signs of a neurogenic bladder? So something like a change in their walking or their gait. All of those things are going to help us narrow down what is contributing to this new problem they're having. The first step of management for enuresis is simply to try some behavioral modification. So that's our first thing. Patients and kids are going to be encouraged to void every 1.5 to 2 hours during the day. They should avoid caffeinated and sugary drinks after 4 p.m. because those are going to increase the likelihood of them bedwetting. And then they're going to have their parents make sure that they urinate immediately before bed. And then parents may even do a purposeful wake up in the middle of the night to empty that bladder and hopefully decrease the chance of them wetting the bed. If these things aren't effective, then we may go on to try something like a bed alarm, and that actually it works to wake up the patient as soon as they begin to void, to try and help establish new patterns where they're waking up and then going to the toilet. Medications are our last attempt, and they're only going to be used if those other two don't work over some time. And the medications that we use are desmopressin acetate, which is the same thing as DDAVP. And then that just works to increase water absorption in the body and then decrease urine production overnight. Anticholinergics like oxybutynin may be used to stop bladder contractions, which can also prevent and reduce urination during the night. Now, for all of these things throughout the whole process, emotional support is super important. This is very distressing for parents and kids because it adds a lot of work, and parents are having to wash sheets all the time, and kids are worried about it. And so it's really important that we involve kids in all of the management so that they can feel really empowered. We want them to be giving ideas and what might help and what might work. And all of this will help fight against a lot of the shame and guilt that kids may have. And then it's also important that parents know that enuresis is not a symptom of bad parenting, and it's also not an act of willful rebellion or misbehavior on the kid's part. Your priority nursing concepts for a PEDS patient with enuresis are elimination, human development, and coping. All right, let's go over your key points for this lesson. Enuresis is when a kid is not able to have control of their bladder after the expected developmental age, which is usually 5. It can be classified as primary or secondary, and it can affect the kid day or night or both. There are a lot of different variables and diagnosis to consider when we think about what could be causing this problem, but the most important that we need to rule out are diabetes, UTI, constipation, and neurogenic bladder. During your assessment, you really want to pay close attention to finding information about their voiding history and also just about their life and their routine so we can pick up clues for how to best go about managing this. The first step of management is all about behavioral modifications, and the most important changes they need to make are to ensure routine toileting throughout the day, and then they also need to void right before bed and avoid caffeine and sugary drinks late in the day. Medications that can be used are desmopressin acetate and oxybutynin, but again, these are only going to be used after we've tried other things like behavior changes and the bed alarm. Okay, you guys, that wraps it up for our lesson on enuresis. Make sure you check out all the resources attached to this lesson. Now, go out and be your very best self today, and as always, happy nursing.